Limited Singapore, JPL, is engaged in manufacturing and supply of radiopharmaceuticals within a network of 48 radiopharmacies in the US, allergy immunotherapy, contract manufacturing of sterile injectables and non-sterile products, APIs and solid dose formulations through 6 manufacturing facilities that cater to all the regulated markets, including US, Europe, and other geographies. Jubilant Pharmova Limited has a team of over 6,000 multicultural people across the globe. The company is well recognized as a partner of choice by leading pharmaceutical companies globally. The India branded pharmaceutical business is one of the fastest growing within the cardio-diabetes in India, with a large distribution network pan-India. Today, we have with us Dr. V. Mohan, Chairman, Dr. Mohan's Diabetes Specialty Center and President, Madras Diabetes Research Foundation, Chennai. His mainstream research interests are epidemiology of diabetes and its complications, genomics of diabetes, fibrocalculus pancreatic diabetes, and precision diabetes. Conferred fellowships from all the 4 Royal College of Physicians and all 3 Science Academies of India, including Fellowship of Indian National Science Academy. Dr. V. Mohan has received over 190 awards, including the Dr. B.C. Roy National Award by the Medical Council of India and the Dr. B.R. Ambedkar Centenary Award for Excellence in Biomedical Research from the ICMR, the highest award for biomedical research in India. In 2018, he received Dr. Harold Rifkin Award from the American Diabetes Association, and he's the first Indian to receive this award. Published over 1,430 papers in peer-reviewed journals and textbooks, ranked among top 2% of scientists in the world and highest ranked scientist in Tamil Nadu by Stanford University, and amongst top 0.1% of researchers in type 2 diabetes by expert scale. In 2012, Dr. Mohan was also awarded the Padma Shri from the Government of India. Dr. V. Mohan is also an author of the book Making Excellence a Habit, which is a bestseller on Amazon India. So without any further ado, it's my privilege to hand over the session to Dr. V. Mohan to take this forward. Thank you. Over to you, Dr. Mohan.
Thank you, Vikas. I'll just get my slides and then start my talk.
Sure.
I hope you can see my slides. Can you see?
Yes, yes, absolutely.
So a big thank you to Amit of Nutrify today, Vikas Banshi and Sandeep Mahobia of Jubilant for putting together this very important session on nutraceuticals. It is not often that we discuss nutraceuticals, and I think it's very appropriate to discuss this today, being World Diabetes Day in India. As you know, World Diabetes Day is celebrated to commemorate the birthday of Dr. Sir Frederick Banting, the person who discovered insulin. Today also happens to be Children's Day, and it's very important that children get their nutrition right, because recently we read that there are 32 million people with malnutrition in India. So it all kind of coincides very well, and therefore I'm very happy to be here with you today and to wish you all a very happy World Diabetes Day. So on that note, the topic of my presentation is intervention of emerging and responsible nutraceutical ingredients, the management of cardiometabolic diseases. This is the outline of my presentation. I'll talk a little bit about cardiometabolic diseases and then specifically about 2 products, the omega fatty acids and coenzyme Q or CoQ10, and then give you some concluding remarks. Now, when you talk about cardiometabolic burden, all over India, this has become a huge problem, and all over the world actually, but India is a kind of diabetes capital and heart attack capital, because we have known for many, many years, at least 40, 50 years now, that South Asians somehow, South Asian in general, Indians in particular, have somehow this cardiometabolic predilection to cardiometabolic diseases. And one of the factors which could be responsible and which is very characteristic of South Asians is listed right on top, and that's a low HDL. So you know that you have the good cholesterol and the bad cholesterol. And this good cholesterol or HDL, there is no doubt at all that South Asians in general, Indians in particular, have the lowest HDL in the whole world. Now, why is this so? In fact, I used to say that if you give me the HDL, if you let me know what's your HDL, I can just let me know your HDL, and with 90% accuracy, I can tell you whether you're Indian or not. Because if it is really low, there's very few other races where they have a low HDL. Of course, occasionally Indian can get a high HDL, very, very rarely. That's why I said with reasonable accuracy, about 90% accuracy, just by looking at the HDL. The other way is you mix all the HDLs of different people. I can pick out the Indians and the non-Indians out just by looking at the HDL. It's so characteristic. We have been studying this for a very long time, whether it is due to genetic factors, could be. We have found so many lipoprotein lipase genes and ApoE genes and many others. But it could also be due to our habits, the high carbohydrate diet that we take, which increases the triglycerides, which is mentioned here, and also leads to the small dense LDL pattern or the atherogenic dyslipidemia, and most importantly, the low HDL. Because all this leads to a prothrombotic state and inflammatory markers and increased oxidant stress and glycations. And on this side, we have some of the causes: sedentary lifestyle, lack of exercise, stress, smoking, obesity, all of which, of course, lead to hyperinsulinemia initially, then to low insulin levels causing diabetes, and then, of course, producing atherosclerotic heart disease. And if you take these three separately out, the glucotoxicity, where you have high glucose levels and insulin resistance, and then lipotoxicity, and then lifestyle, they all kind of converge. And this produces a kind of meta-inflammation and produces various cardiometabolic manifestations. An instance in point is that while the whole world had COVID-19, it was only in India that we had mucormycosis. For some strange reason, we still don't know what it is that produced it, but India had the worst case. We didn't even hear of mucormycosis in any other country. I believe it's because of the very high prevalence of diabetes and certain other metabolic patterns that we have in India that this happened. Now, cardiovascular risk, of course, is not just an Indian phenomenon, it is worldwide. And if you take all CVDs, ischemic heart disease or coronary artery disease will be right on top. There are many others, rheumatic, non-rheumatic, and others, but they're all kind of going down. But ischemic heart disease, ischemic strokes, these are the ones which are predominating. Of course, you can add atrial fibrillation, cardiomyopathy, hypertensive heart disease, which are also emerging. But the predominant cause is ischemic heart disease. And this is data from the Global Burden of Diseases, where they've looked at what are the causes of the CVD burden. And you can see that right on top comes high blood pressure, dietary risk, high HDL. Of course, this varies from country to country. In high-income countries, you don't find this air pollution and all that coming up. But in low-income countries, you'll find air pollution is right there on as fourth place, probably moving up now as better control of blood pressure and LDL cholesterol and all that is okay. We recently showed, as part of another study, that LDL levels are actually getting under control because of the use of statins. But things like this, we recently just read yesterday that some parts of India, like New Delhi, they're considering a lockdown for pollution. I mean, we never heard of this anywhere else in the world, a lockdown for pollution, you know. So things are happening, which not all of which is desirable, but all this ultimately leads to this huge burden of cardiovascular disease. And this is again data from the GBD study in India, showing state-wise where you have the hotspots of cardiovascular disease. And as you can see, Punjab, Kerala, and Tamil Nadu probably come as the #1 position in cardiovascular disease. And take ischemic heart disease alone, then Maharashtra also gets added. And then there are some parts where still it is a little low. For example, UP and the Northeast and so on, where perhaps due to genetic factors or because their physical activity is more or some reason it is low. But every 10, 15 years, it starts increasing. In fact, it's very interesting statistics. I was part of the GBD India study where we published diabetes and heart disease actually. And when you looked at 1990, we also looked at another way. What was killing people? What are the mortality rate due to? Is it communicable diseases or non-communicable diseases? It's interesting that in 1990, there was only one state which had more non-communicable diseases than communicable diseases, and that was Kerala. And Tamil Nadu was almost there. If you take a ratio of 1, which means communicable, non-communicable is to communicable, 1 means both are equal. More than 1 means non-communicable is more. Only Kerala had more than 1 in 1990. By 2020, almost all the states in India had a ratio more than 1, which means communicable disease has gone down and the non-communicable diseases had definitely increased. And that includes diabetes, heart disease, and so on. So where does the omega fatty acids fit into all this? We know that there are many essential fatty acids, and the two major ones are the omega-6 and the omega-3. And we know that the omega-3 is the healthy one, which if you have much lower incidence of heart disease and diabetes and so on. And we also know that the two major drivers, for example, of the diabetes and heart disease epidemic are two faulty things in the diet. One is carbohydrate itself. We have shown that excess rice intake or excess refined wheat intake leads to diabetes. So that's the carbohydrate route. But if you look at the fatty acid route or the fat route, then there's an imbalance between the omega-6 and the omega-3. And this is very predominant in South Asians and in Indians. So the omega-6 pathway, we take a lot of omega-6, but very little of the omega-3. And if you have a ratio of omega-6 predominating over omega-3, then you are more prone to heart disease and including diabetes. Elegant work from Dr. Gafurunisa from National Institute of Nutrition has shown the importance of this, the omega-6 and omega-3. She spent a large amount of her life devoted to this. And of course, the omega-6 comes from the vegetable oils like sunflower oil and safflower oil and so on. Many years ago, we used to take only saturated fat. But then the big move came in the 1980s, where these sunflower oil and safflower oil were introduced by industry. And almost everybody changed to that. And once you change to this, what happens is your linoleic acid goes up. And this goes down this pathway, arachidonic acid, and so on. And this omega-6 is also dominated by meat, poultry, and eggs. So predominantly non-vegetarian sources here, but also if you take the vegetable sources, sunflower oil. So if you take too much of this, then you get the omega-6. Now, omega-3, unfortunately for vegetarians, it is a little difficult to get this omega-3, and that is where supplementation becomes very important. In the case of non-vegetarians, you have to take oily fish. So instead of taking the red meat, if you took oily fish, then you get eicosapentaenoic acid or docosahexaenoic acid, EPA or DHA. But then oily fish vegetarians don't get. So this route you don't get in vegetarians. And so you have to go higher up the pathway, and you get some from green leafy vegetables, but you also get from flax seeds and chia seeds, walnuts, soybean oil, canola, and so on. But invariably, you have to supplement. And that is why supplementation of omega-3 becomes very important if you want to balance out this imbalance between omega-6 and omega-3. Now, the types of course, the role of omega-3 is well known in cognitive function, cardiovascular disease, muscle and bone, immune system, etc. And if you go deeper into the omega-3 fatty acids, you have the ALA or the alpha linoleic acid, you have the SDA or the stearidonic acid, and the eicosapentaenoic acid or ETA, EPA, which is very important, eicosapentaenoic acid, And then you have, of course, DPA and DHA. So these are all and that's the chain, fatty acid chains, which are shown here. So when you talk of omega-3 fatty acid, it's not just one, but you have several of these. And that, of course, was shown in the earlier earlier slide, where you can see where all these fit in. Now, the effect of EPA and DHA on different cells are shown here. They have multiple beneficial effects as far as the CVD is concerned. They have anti-inflammatory effects, so they work on the monocytes, works on the platelets, and therefore have anti-thrombotic action. They have a hypolipidemic effect, and finally, they have an anti-inflammatory and vasodilator effect. So you'll agree that all of these are very good as far as the cardiovascular system is concerned. Just for completion's sake, so that you know that it's not just omega-3 and omega-6 which are there, there is also omega-5, 7, and 9, much less studied, and omega-7 is believed to have some properties essential to regulation of blood sugar and fat. It's a very complicated system, and I won't bore you with that. And so too for omega-5, which is shown here. It's considered a powerful antioxidant and to reduce lipid peroxidation. Suffice to say that if you get these fatty acids also, it is good for you, but the work on these is not as robust as on omega-3 and omega-6. And of course, there's also omega-9, which is supposed to be a natural agonist of the PPAR, or the peroxisome proliferative activated receptor, which, as you know, plays a role in diabetes. We know, for example, that pioglitazone works there, and we have the PPAR pathway, which is supposed to be involved in glucose transport and also in microvascular dysfunction and so on. But again, not too much data on this. So let me go on to omega-3 itself, and what is the data that we have to show that it is useful. First, let's look at the inflammatory markers. Here are studies with different studies. These are kind of meta-analysis of different studies which have been done through the years, different numbers of people studied, and then the overall effect shown here. And I'm sure all of you are familiar with this forest plot. So if you draw the forest plot and you mark the zero mark here, and then on one side, you can see when you're comparing something with, say, a control group. In this case, the N3-PUFA is being, the omega-3 PUFA is being compared with the control, where you don't use it. If you get these markers coming on that side, it means that it favors the N3-PUFA. And if it comes on this side, it means that it is favoring the control group. That means it's actually harmful or whatever. And then if it's in the middle, it means it's a null effect. It has no effect. So if you look at and when you have different studies done on different subjects, study numbers, you might find contradictory results. And that's why a systematic analysis and a meta-analysis is done. And so if you look at the overall effect, it is, so if it is minus, it's a negative effect. And if it's a positive, it's a positive effect. So you can see it's almost 3. The Z score is almost 3. And you can see if you pool all these studies together, it goes very much on to that side. If it crosses the unity, it means it is not significant. But it is not crossing the unity. Of course, some studies are 1 or 2 are on this side, 1 or 2 are neutral. But you can see the majority of studies are on that side. So there is no doubt that it reduces the inflammatory markers and has a positive effect on that. There are separate studies which have been done, some on EPA and some on DHA, which have looked at CRP concentration, specifically in people with type 2 diabetes. And again, this data is even more robust. As you can see, it is clearly on that side for almost all the studies, virtually nothing on this side, showing you, irrespective of which study has been used, it reduces the CRP. And we know that CRP became popular during COVID-19. Everybody started measuring their CRP. CRP, of course, is a non-specific inflammatory marker. It's not a specific marker for COVID at all, but it shows you inflammation. And so if it is on this side, it shows that it is reducing the inflammation. Now, there are other studies which have looked at adipocytokines, and they have looked at people with pre-diabetes and type 2 diabetes. And the only friendly adipocytokine, I know most of the adipocytokines are harmful or inflammatory. The one which is a friendly one, like your HDL being friendly, the friendly one is adiponectin. Anything, and of course, Indians have very low adiponectin as well, just like they have low HDL. One of the things about Indians is that they have very low adiponectin. We and others have shown that. In fact, progression from pre-diabetes to diabetes, adiponectin goes down. And TNF alpha, of course, is the inflammatory one, inflammatory cytokine. So exactly what it should do, the supplementation of the omega-3 result in an increase in adiponectin and decrease in the TNF alpha. And this is looking at the risk of type 2 diabetes in general, okay, whether omega-3 has any effect on type 2 diabetes risk itself. This, I was not actually very much aware of this. I was thinking of it more from the cardiovascular until I started preparing for this talk. But I was surprised to find that, a very strong effect in actually preventing diabetes. You can see most of the studies on this side and very few on this side. And the meta-analysis clearly coming out to be on that side and highly significant. So there is evidence that by taking omega-3, type 2 diabetes risk can be lowered. And of course, I have done some work on this. For example, in our studies on oils, we showed exactly what was shown here, that those who took the safflower oil and sunflower oil, the polyunsaturated fatty acid oils, they had a higher incidence of diabetes and metabolic syndrome. We showed this in our cross-sectional studies in cures and also in our longitudinal studies. Whereas oils which contained more of the monounsaturated fats, like, for example, groundnut oil or mustard oil or gingerly oil, they had a beneficial effect, particularly on the HDL, where the HDL increased after using MUFA, whereas HDL went down if you used the other vegetable oils like the safflower oil and so on. Not all people accept these findings, but our findings were very clear and they're based on very large numbers of population-based studies. We had not directly looked at the diabetes part of it, but Gafurunisa, as I mentioned, has done, I don't know whether the studies are included here, but she has definitely data to show that whenever I talk about carbohydrate being the cause and rice and polished rice, she used to say, no, it's this one. It's the omega-3 lack and the omega-6 to omega-3 ratio. In every meeting, she used to come up and talk about that. So here is again data on GDM and the effect of omega-3, a specific group of diabetes which comes during pregnancy. And if you look at the effects on fasting blood glucose and insulin levels, there are beneficial effects shown in this particular study as well. And again, beneficial effects on HOMA-IR. HOMA-IR, as you know, is a marker of insulin resistance, calculated using the Oxford model and using fasting insulin, fasting glucose. You can measure the HOMA-IR, and this is showing beneficial effects there. Now, there have been some studies which have been neutral as far as HbA1c is concerned. So if you're saying, will this help to control diabetes? We don't have enough evidence for that. Probably in the etiology of type 2 diabetes, in reducing inflammation, in pushing from pre-diabetes to diabetes, slowing it down, all those it may have benefits, but it did not affect the HbA1c. So it's not an anti-diabetic drug. So it's not supposed to, but at least on the other hand, it didn't increase HbA1c. Now, this is the effect of EPA, DHA, and ALA on cardiometabolic risk factors. And one of the things which came out interesting in these studies, which of course needs further studies, is that there's a very nice reduction in the triglycerides and an increase in the HDL, but there was a slight increase in the LDL as well, which is probably not significant. Many of these studies are based on small numbers, and we need much larger studies to confirm this. Here again is a study on omega-3 on glucose levels and lipid levels, and it is showing a very nice, and of course there are now big studies which have looked at the effect of triglycerides And I think it's fairly well accepted now that your triglyceride levels will go down after omega-3. There are huge randomized clinical trials published in New England Journal of Medicine, which are showing this. Now, let me change tracks and go to another interesting subject, that is the subject of coenzyme Q or Q10, CoQ10. So what is CoQ10? Coenzyme Q or CoQ or ubiquinone plays an essential role in mitochondria. So this is at a different level. It's working. It's working on the mitochondria. And you know, the mitochondria is a powerhouse of energy. And so it plays an essential role as an electron shuttle between complexes 1 and 2 of the respiratory chain and complex 3. It's also a cofactor for other dehydrogenases. It's synthesized by mitochondria by a set of at least 12 proteins that form a multi-protein complex. And this is the complicated slide which tells you how it works. And it's been shown that one of the mechanisms by which the statins work is by reduction in the CoQ10. So when you take statins, there could be a reduction in the CoQ10. And therefore, if you're giving a CoQ10 supplementation in those who take statins is a very good thing. And I find a lot of the cardiologists prescribe and lipidologists prescribing this along with the statins. I won't spend too much of time on this, but this shows you the structure of the CoQ complex in the mammalian cells and how it is involved in its metabolism. Is there any evidence on the CoQ10 and cardiometabolic diseases, particularly diabetes? Here is this interesting study published by Hodgson in European Journal of Clinical Nutrition, that if you look at compared to a placebo and phenofibrate arm, those who were taking the CoQ10 had a decrease in the systolic blood pressure, and interestingly, a decrease in the HbA1c as well. Small studies need to be done in larger numbers and also in our population, but showing at least some beneficial effects as far as cardiometabolic. It's not just HbA1c, but also BP. So therefore, probably helping metabolic syndrome in general. The effect on HbA1c is not very clear, but there is a suggestion if you do a meta-analysis that so on this side, if you get negative, it's favoring CoQ10, and here it's favoring control. And if you just look at the midline and look at how many are on that side, very few on that side, more are on this side. And if you take the overall effect, it is a beneficial effect as far as the HbA1c is concerned on CoQ10. So not only it helps in the metabolic process, but also might help in the glycemic control as well. And this is a further analysis of the same thing, again showing you that most of the studies are on this side of the graph of the forest plot. This is on fasting plasma glucose, favoring the CoQ10. And most interesting of all is the effect on the HDL. I did mention that the low HDL is one of the characteristics of South Asians and Indians, and we have very few drugs actually to increase the HDL. The only way you can do it is by rigorous exercise, and even that is not very effective. So there is controversy as to whether alcohol will increase HDL. There are some views that it increases the wrong HDL. There are different types of HDL, and it doesn't improve the correct HDL. So alcohol is not an answer. Exercise, yes, it does improve, but there are very, very few other drugs which actually increase the HDL. If you give a statin, what happens is everything comes down. So LDL comes down, total cholesterol comes down, HDL also comes down with a statin. And the CETP kind of drugs which increase HDL have all failed, as you know. They failed in the clinical trials. Although theoretically they're supposed to work, they don't have. So for this low HDL, which I talked about in the beginning in Indians, we really don't know what to do. They may be walking every day, but the HDL still remains low. So in this context, using the CoQ10, where you can see a definite increase in the HDL cholesterol, seems to be a beneficial effect. So the take-home messages from this short presentation are that omega fatty acids have an important role in diabetes and CVD. we need more data in the Indian population, particularly in those with type 2 diabetes. And the role of CoQ10 is also promising, but again, more data is needed. So I'm going to thank both Nutrify today as well as Jubilant for putting this together. And thank you all for joining on World Diabetes Day. It's a Sunday evening, and I know you have other things to do, but I believe a large number of you have registered. So once again, a happy World Diabetes Day to you and my greetings. I'll now stop sharing, and if there are any questions, I'll be happy to take them. Thank you.
Thank you so much for that insightful presentation, Dr. Mohan. So we do have a lot of questions, to be fair, but in the interest of time, we'll pick perhaps 5 or 6 of them. So starting with the first one, Doctor, how can omega be beneficial if taken in the right combination with trending ingredients like 5-MTH versus just taking plain omega-3?
So I suppose if we have other products which are specifically suited for improving metabolism and can have an added advantage rather than just taking one compound, obviously you can get beneficial effects. One of the things which people are worried about when they take omega-3 is whether it contains any fish or any animal products. That's one of the things which people worry about. Vegetarians, for non-vegetarian, there's no problem. And in my state, 98% are actually non-vegetarians. In Tamil Nadu, only 2% are vegetarian. But I know there are states where more than 50% are vegetarian. So they do ask, does this contain anything? Even for calcium, they worry. Does it contain shell of an egg? Does it contain this? Can it contain that? But I believe that there are now products which are purely vegetarian also which have come, which is a great thing. And as I said, for vegetarians, it's a big problem to give, enough of omega-3 and so on. It is not easy. So any of these with added benefits will obviously be very good.
Great. And since you spoke about veg omega and non-veg, I think the most obvious question, but still we've got a lot of repeats on this. Doctor, does veg omega offer the same benefit as non-vegetarian omega? And that's quite a tricky and important one. But
yeah.
I
don't think in other countries they would even worry about this. I've not heard this in a Western kind of atmosphere where they talk about this even because they take everything. So there's no food restrictions. I mean, we have to see the studies are not clearly done using this and that. And I have not personally done studies. I'd be happy to look at such studies and measure a few things. Most of these parameters that you mentioned, whether it's CRP, HSCRP, or TNF-alpha, adiponectin, these are all things which we do. So I'd be most happy to look at specific effects of these in Indian populations. I don't think that there should be any difference in that if the formulation is made in such a way that the right ingredients are given. Otherwise, it's a no-no for vegetarian straight away, isn't it? We can't give it at all. But the choices are limited. We don't have too many with which offer this. So that to some Indians, it would be a beneficial effect. For the others, it really doesn't matter. So.
All right. Now, there are a lot of trending ingredients, and we keep hearing about it, and a lot of patients have these queries. For example, ingredients like ALA, resveratrol, and there are a lot of common queries that keep coming around this. How beneficial are these ingredients, if of course taken in the right combination, because that is the job of the nutraceutical industry to deliver. But so, Doctor, your thoughts, your views on these trending ingredients like ALA and resveratrol, how beneficial are they? What is your take?
ALA, is definitely good for neuropathy. About that, we have no doubt at all, because in many of the products given to improve neuropathy, diabetic neuropathy, and other peripheral neuropathies, ALA plays a big role. Apart from its cardiometabolic benefits, the neural benefits are very clear with ALA. And there are a lot of studies on that as well. Big chapters have been written on that. But regarding resveratrol, see, the thing comes from the French wine and the paradox, and how beneficial it is, and so on. And again, there are a lot of people who don't drink and who still want to get the benefit of that. So adding the active principle onto that is definitely beneficial. I'm not an expert in this, but the effects of this, there are studies, but the effects of this still need to be, obviously it's not going to do any harm, but the real beneficial effects of it, and that too in our population, I'm not sure whether Indian studies have looked at it, but I think these are things which are definitely worth researching and studying in our population.
Great. Now, in the overall backdrop, what would you suggest about the supplementation of these supplements in general for diabetic population or for with, metabolic disorders? So, what is your view on these supplements?
Given that if there is not all people with diabetes have the same cardiometabolic risk. We know that. Today we have scores to calculate your cardiometabolic risk and your 10-year risk of getting a heart attack, or equivalence of, we don't have the Framingham kind of score as such in Indian. We are working towards it. I work closely with Dr. D. Prabhakaran of CDC and PHFI, where we collaborate, and we're trying to actually produce, through our CARS study, we're trying to produce such a score. So if you have a history of coronary artery disease, if you have severe cardiometabolic complications and the severe dyslipidemia, or uncontrolled diabetes, and multiple facets of the metabolic syndrome, I think using this is definitely justified. There's no harm in using them, but whether across the board every diabetic person should be given it and will get benefits, we don't know. Actually, there's no one size fits all, as you know. There's a lot of heterogeneity within diabetes. So maybe a quick risk assessment is something which can be done, and then we can give these products. See, for us, we actually use an Indian diabetes risk score, where using age, family history of diabetes, and whether you do physical activity or not. 3 questions. Do you walk regularly? Does your father and mother have diabetes, and your age? Only 3 questions. And then a waist measurement. With this, we can clearly find out not only who's at more risk of diabetes, but also at risk of heart disease. Because if you think about it, age is a risk factor. Family history of diabetes produces insulin resistance and gives you that. Lack of exercise is a major risk factor, not just for diabetes, but for heart disease. And waist is the best indicator of metabolic syndrome. If you have a big waist, you have metabolic syndrome. You don't need to do triglyceride or HDL, or you don't even need to check your weight, because waist is a better predictor. So with these 4, you can easily, so anybody who has this high risk, such a simple thing to do, if you think about it, takes 1 minute and 0 rupees. Ask the age of the person, ask whether the father or mother had diabetes, whether you do exercise, and if yes, is it mild, moderate, or severe? Because there are marks given for each of the scores given for each of them. And then do the waist measurement. So it's below 90, or between 90 to 100, or more than 100 for men. For women, it's below 80, 80 to 90, or more than 90. Simple. It takes 1 minute to do. You can do it online. And with that, you know your risk. I mean, can't get simpler than that. It took us 20 years to find this out. Once we found it out, it's kind of ridiculously simple for anyone to do. I would say anybody with a kind of high risk, then you can take these, because I think it can help to reduce your risk.
Sure. And like you just mentioned, so could there be other contributing factors that could possibly impact the effects of these fatty acids and CoQ10 on cardiometabolic outcomes? So how is it specific to the diabetic population?
I don't think it is actually specific to the diabetic population, because see, even people even without diabetes get heart attack, no? Macrovascular disease is not specific to diabetes. Microvascular disease is specific to diabetes. We're talking about retinopathy, nephropathy, and neuropathy. Those are specific to diabetes. But for strokes and for heart disease and metabolic syndrome, these need not be present in a person with diabetes alone. Anybody who's overweight, anybody who has increased abdominal obesity or central obesity, is already at risk. Incidentally, they may have diabetes also. A large number of them will have diabetes, but the risk remains the same even without diabetes. We hear of young Indians, even without diabetes, getting heart attacks and at the age of 30, 40. We heard of people, they didn't have diabetes. Before that, they have the heart attack. So that's why I said we are like the heart attack capital of the world. And this is so much more compared to any other ethnic group. To compare with the Japanese or the Chinese or even with Southeast Asians, if you compare, we have the highest risk. We still don't know why. 30, 40 years we've been looking at it. What is this? What is it? But it's accepted that we have the risk. So there are certain things which are very characteristics of South Asians and Indians. Okay, when I say South Asians, includes Bangladesh, Pakistan, Sri Lanka, Nepal, Maldives, India, Nepal. So these 5, 6 countries behave in a very uniform way. And whether you study them in the UK or study them here, or you study them in Fiji, or study them in Maldives or in Mauritius, or the same way, they come out in a very peculiar way compared to, say, Chinese or other populations. So the low HDL is one, the high triglycerides is one, the hyperinsulinemia leading to a quick, beta cell exhaustion, and then the coronary artery disease occurring at young age and more severe coronary artery disease. These are all established factors. And then you have the high HSCRP, and then you have the low adiponectin. And if you measure TNF alpha, it will be high. They also have low vitamin D. They have the low B12, especially in the vegetarians. So all these are characteristic, what Dr. Yajnik calls as a thin fat Indian. So you may look thin, but there's a lot of fat. And even on the day of birth, he has shown that the newborn child itself has it. So something intrauterine about, he believes it's all B12. And if you give B12, it will get supplemented. Could be true, but nothing in medicine is due to one factor. It's always multifactorial. So we definitely qualify for using this.
Correct. We have a couple of more, but I'll take this one. Is the hypothesis of supplementing CoQ10 in patients, particularly on statins, beneficial?
The evidence suggests that I have not seen guidelines by any association saying that all patients on statins should be put on CoQ10. And I found invariably the cardiologists including it when they write that. Among the diabetologists, I don't think this concept has caught on yet. In the diabetic associations and RSSD and so on, I don't find this being popularized so much. But it's something which definitely merits study. And if there are any consequences due to long-term statin use and so on, if this is something which can help, I think it's good. It's worth, again, I think, doing a study. My suggestion would be 2, 3, not very big studies, but medium size or smaller to medium size studies, looking at one group with statin without CoQ10, one with statin with CoQ10, and then measure a few parameters and see what happens. For example, you can even measure the carotid intimal thickness and see whether there's any change in that. Is there any change in arterial stiffness or something like that? We can't wait for hard endpoints. We cannot wait for all of them to get heart attacks and strokes and die and so on. That will be too long a study. We can't do it. But these short-term studies, 3 months, 6 months kind of studies are enough to produce good evidence and see how they work.
One favorite and perhaps last question, I'll take it there is, could there be possibly any harmful effects of these fatty acids on cardiometabolic outcomes in your experience, doctor?
It's been mentioned that there's a small risk of hemorrhage. So especially brain, very small risk that it could lead to small leaks or but I think it is more exaggerated, and I don't think for the number of people who consume that it's like taking aspirin. Well, of course, aspirin is much more. The bleeding with aspirin is much more than this. But there's probably a very small risk of that. And that is why I think a physician should just over the counter taking it may not be a very good idea. A physician should be involved in the treatment. But this is something which people write about, little increase in fragility and things like that. But I don't think it's a major concern, because in that case, all those who eat fish should be getting more of those. In fact, we have done a major study on fish itself, and that is published in JAMA actually this year, beginning of this year. But I'm also involved, apart from the large Indian studies, the CURE study, the INDAB study, and so on. One of the big studies I'm involved in is PURE, Prospective Urban Rural Epidemiological Study, and this started in India. And now Salim Yusuf, the guru of cardiology, runs this remarkable study, which is done in 21 countries, 5 continents. It has enrolled more than 150,000 people who have now been followed for 15 years minimum. We plan to follow for another 15, 20 years. And the whole cohort, and the cohort is growing. First we had 8,000, 10,000, then 50,000, 110,000, 150,000. Now I think we have close to 200,000 people. And the duration of follow-up is going on and on. Those who were first registered, it's a longitudinal follow-up study. Every year we follow up these individuals. And about 30,000 of them are from India. And we have an equal number from China and from 21 countries in 5 continents. And we are part of that. I'm one of the steering committee members of that. And the diabetes studies I've been involved. This rice one I told you came from there. Okay. Rice before and after 15 years follow-up. Those who took rice 15 years ago, what happened to them? Who developed new onset diabetes? We have excellent data on mortality, because every case which dies in this cohort has a verbal autopsy done. It's the world's best study. There's no study better than that. All New England Journal, Lancet publications. So it's worth looking at those kind of data to see what happened and people took this. Of course, they're observational, they're not interventional,
sure.
But longitudinal studies. So they're follow-up studies, they're not cross-sectional. So there are very few confounders of studies. But we can do also intervention studies, short-term, giving this and not giving that, and then seeing that. So we'd be happy to get 2, 3 interested people in India and work on this.
Sure. Great. I think that was a fantastic session, and thank you so much. We took some extra questions as well, but I think in the interest of time, we should, and considering your busy schedule, thanks for taking out time. So, Amit, over to you from here.
Thank you, Vikas. Dr. Mohan, every time you come on our platform at nutrifytoday.com, you leave me thinking on new topics to work on. So you seem to be always on something new. Doctor, nutrifytoday.com is a platform that has stringent curation process, and it's this reason only responsible nutrition companies are allowed to organize program on our platform, and only leading healthcare professionals with good social service record are allowed here. We had an opportunity. You have been on our platform earlier. We also had an opportunity to have the president of IMA, president of FOXI, IAP, then senior professionals from FSSAI, MATSA, NPRA, which is a Malaysian government regulator, Institute of Natural Medicine president, USA, Japan, and other countries. Because it is always an honor to work with you, because you're always up to something innovative and disruptive. Nutraceutical do not follow the reductionist approach of pharmaceuticals, as these are active biochemical compounds. For example, when we look at essential fatty acids in gas chromatography, we see peaks of most spectrum of essential fatty acids like omega-3, 5, 6, 7, 9, and even omega-12. Now, when we get a high peak of omega-3 in the spectrum, we call it as omega-3 oil. But that doesn't take away the other peaks from the oil. Now, what is interesting that you have worked on, and that's why I praised you, it was not for the sake of it. When you worked on these products, multi-omega and UB Gold, I like the fact that you have managed to pull up a peak high for omega-3, 5, 6, 7, and 9, while you could manage to suppress the other peaks on that fatty acid complex. And that brings us to the logic of probiochem. our body needs nutraceutical in whole form. Now, by improving the peaks of other essential fatty acids, we can obviously see a better health outcome in cardiometabolics. Now, the concept of probiocambience is creating an ambience in the biochemistry of body for the target ingredient to perform optimally. Now, to give a real life example, it's similar to a war field. In a war field, there's a military deployed at the front. And to support that military, there's a backup support military which provides a cover up so that the front military does its job in the best possible way with least damage. Now, in the logic of biocambience, drug is the military on the war front. Now, for minimalistic dose of drug to work at an efficiency, it is important that an ambience is created so that there's no need to increase the drug load. Now, evidence-based nutraceuticals are actually the adjuncts, which provide the backup support or cover, which creates a biochemical ambience for the drug to perform optimally. And this brings us to a better health outcome for the patient and better returns optimization on therapy. I seriously recommend companies to explore varied applications of biochemicals. Now, the innovation is, when you used 6S5-MTH in a creative application of ingredient to manage homocysteine levels in body. Now, this ingredient, when you combine it with essential fatty acids combination, certainly has a much better cardiometabolic implication, but then as a good supplement, it's also renoprotective. Obviously, if you bring down the homocysteine level down, it will be renoprotective. So certainly, Vikas, good work done along with Jubilant on multi-omega and UB Gold. And Vikas, I look forward to your leadership in building more responsible nutrition portfolio in Jubilant Pharmaceuticals. I think this is something you must do. Thank you very much. And thank you, Dr. Mohan, very much.
Thank you. Thank you for inviting and have a good day.
You too. Bye-bye.
Thank you so much.
Bye-bye.
Thank you so much, Dr.
Thank you.
Thanks, everyone. Bye-bye.
Bye-bye.